Good evening, everyone, and thank you for spending your time with us today for our Women's Health webinar. I'm your host, Katie Lucas. We are excited you have chosen this platform to learn more about this condition that affects millions of women around the world. We'll start with a few housekeeping items, and then I'll introduce today's speaker. First, your participation in today's webinar is completely anonymous to other attendees. No one can see your face or your name, and any comments or questions can only be seen by myself and our speakers. If you wish to ask a question, please type it in the chat box at the lower part of your screen. We will address questions at the end of the presentation. Our presentation today will last for approximately 30 minutes and will be presented by Dr. Connie Marks. Dr. Marks is a highly skilled urologist at Advanced Urology Associates in Illinois. She attended medical school at Harvard University. Then she completed her urology residency at the Glickman Urological Institute at the Cleveland Clinic. Dr. Marks specializes in treating a broad range of female urological conditions. Dr. Marks, thank you so much for joining us this evening, and I'll turn it over to you to get us started.
All right, can everyone hear me? Good evening. Hi, so I'm Dr. Connie Marks. Great, so thank you everyone for taking a little time out of your Tuesday evening to really review overview of concepts regarding urinary incontinence, what it is, who's affected, what to expect when coming for evaluation. And before I get into the talk, I wanted to just review a little bit about me. So from our wonderful introduction, you have a sense of my training. I've been in the Joliet and New Lenox area for approximately 13 years at this point. So I see a wide range of urologic problems, but a particular interest of mine is women and incontinence, and also pelvic prolapse, which is a separate scope that we're not going to touch on today. Today, we're going to keep it simple and straightforward, really focus on female urination, what happens when it goes awry, and again, what to expect when you come into us for evaluation. All right, so these are our topics for discussion today. We're going to review the most common types of bladder leakage, and then we'll give a nice survey of the treatment options we will give you when you come in for evaluation. And the one thing I want to stress, every woman is different. So as we'll touch on in later slides, this is a very common issue, but what we do for each patient is individually tailored to her concerns and her individual problems. And how we figure out the best treatment for you is based on the information we gather. And that's what I'm going to discuss in the next few slides. All right, and an overview on urinary incontinence. What is incontinence? Our focus is bladder, not bowel leakage, and that's what we refer to with urinary incontinence. It's when you lose urine beyond your control. Don't feel like you're alone in this issue. We think that it's remarkably underreported. The number of people who have this problem is much greater than we can estimate, but we currently think that 1 in 2 adult women have some degree of urinary incontinence. And this 18 million women in the US with incontinence, I suspect the number is higher, but through embarrassment or just chalking it up as part of aging, a lot of people don't even report it until you ask them directly. All right. Our next sort of grouping of slides, we're going to talk about the most common types of bladder leakage. Not everyone leaks in the same way at the same time and through the same cause. All right. The 2 main types of incontinence, and we'll do a lot of questioning when we see you in office to try to figure out what category you fall into. Type 1 is urge incontinence, and that's when people will feel a sense of pressure or urgency, for lack of a better word, and will then lose urine or at least have significant pressure in the context of that pressure or urgency or pressing need to go to the bathroom. The other main type of incontinence is stress incontinence. And that's when women lose control of urine during physical activity, coughing, jumping, deciding to go running with the kids, or chasing a kid down the street. These are all episodes that can trigger stress incontinence. And these are all things we ask for when you come in to see us for evaluation. The third main type of incontinence is mixed, and that is some combination of the two. All right. To give a sense of the scale of the problem, the overwhelming majority of women will come in with at least stress incontinence, 49% per this slide. Urgent incontinence is about a quarter of the women, 22%. Mixed incontinence, a combination of the two, as I mentioned, still is a very sizable share of patients. I commonly hear from patients like, "Doc, I leak. Why does it matter?" And we're going to get to why that matters. All right. This slide just details urgent incontinence a little bit more thoroughly, I guess. When you hear people describe overactive bladder, this is what we are referring to with urgent incontinence. The common symptoms is detailed on this slide is urinating more than 8 times a day, although there's a lot of variability in that in a given patient, and more than 1 time at night. And as I stated above, it's that strong or sudden desire to urinate. That's really the hallmark of this type of incontinence. All right. Stress incontinence, as I said a little bit earlier, jumping on the trampoline, or "Doc, when I go to lift, I know I got to squeeze my legs." That is stress incontinence. All right. And then within stress incontinence, and we're getting a little in the weeds here, but it's worth noting from a procedural standpoint when we look at treatment, the most common type of stress incontinence is something called hypermobility. With time, life, weight, age, whatever, the pelvic floor muscles will sometimes become weak and the urethra is not supported. So in the setting of situations where they're straining, like lifting or doing a jumping jack, the urethra may move from its normal anatomic position. Nothing you would notice, but something we would look for on exam. And that sort of movement or laxity is very helpful to observe because, again, that shapes treatment. The other type of stress incontinence is far more uncommon, and that's something called intrinsic sphincter deficiency. And as opposed to the whole pelvic floor muscles that support all of the pelvic organs, there's a specific muscle within the urethra that can weaken in certain disease states. And that's when we see this intrinsic sphincter deficiency. It's relevant. This is by far the minority of patients, but it's relevant to note for us as a practitioner because those patients respond in a very specific way to therapies. All right. I'm jumping ahead of the slides, right? I touched on this a little bit earlier. What are some of the risk factors for stress incontinence? We talked about age and menopause, but I see 18-year-old gymnasts with stress incontinence. I see 35-year-old women with stress incontinence after a couple kids. It's a continuum. And the rate of stress incontinence increases with age, but there's no lower limit cutoff. There's plenty of young women I see with stress incontinence. Certainly, pregnancy is definitely a factor. The more, the merrier. We don't know if it's the act of having a child, of carrying a child through pregnancy, the weight that a uterus with a baby puts on the pelvic floor. We don't know if it's that or childbirth itself that is a factor, but the constellation of what happens with pregnancy and delivery certainly can contribute to stress incontinence. Previous pelvic surgery, most importantly hysterectomy, can also predispose to stress incontinence. It's almost like getting a tooth removed. Our bodies are so intricate. Things are in such a specific position that in removing one piece, it sort of shifts the balance. So particularly with the hysterectomy or any sort of surgery that involves removing something from the pelvic floor, that creates instability that can then predispose to stress incontinence. Obesity and increasing BMI, which is body mass index, particularly at body mass indices over 40, we definitely see an increase in stress incontinence. This is so recognized that stress incontinence has now become a secondary indication for approval of bariatric surgery. Weight loss can be a factor, but weight gain definitely can predispose to the development of this condition. Uh, I have a patient who is a baker, and she has lifted an industrial baker, and she has lifted, 30, 40-pound pans of baked goods for decades. And when she came to me for her stress incontinence, I couldn't say that physical activity and and heavy lifting could not, it probably is a factor for her development of this. We're not talking about routine, I helped my friend move and now I have stress incontinence. But, high volume, repetitive, heavy lifting over years definitely can predispose to the development of this condition. Smoking, for reasons that we can't fully explain, we can just say can be associated. I know that people who smoke, sometimes you can get, it constricts blood vessels. And so the tissues of smokers can be less flexible, can be stiffer, and that predisposes to a series of conditions throughout the body. And certainly it can be a factor in the development of stress incontinence. Genetics and family history, for many reasons, it definitely needs to be on the list. And lastly, diet. And I think diet more in association with obesity and body mass index. All right. Less common conditions that we see that predispose to stress incontinence would be pelvic injuries, for the same reasons I discussed before related to pelvic surgeries, or spinal cord injuries, because urination is a very complex act that is all coordinated by nerves. So any disease state that affects global neurologic health, for example, multiple sclerosis, or people with history of stroke, people who've had spinal surgeries and known spinal nerve disease because of arthritis, those patients also tend to have associated incontinence. So when you come in to see us or any other qualified physician who cares for these diseases, we have to ask you about all these things, because we need a global big picture to help us understand how best to help you. All right. And then, again, to complete the whole discussion, mixed incontinence is a combination of stress and urge. And I don't want to leave you waiting, but I want to hold on talking about the relevance of this until we get to treatments. All right. So here we are at treatments. We know nationwide that the number of women seeking evaluation and treatment for incontinence is far greater than the number of patients we see in office. And there are tons of reasons why that may be the case. Just today, I saw a lady who she was too embarrassed to bring it up with her primary care doctor. And she felt she was too young to have the problem. And I think she just reached a point where she'd gotten sick of things and just wanted to come in and check things out. That's what we're here for, right? There's nothing to be embarrassed or shamed about. This is, again, so common and routine an issue for women. All right. Like I was talking to my mother the other day, who's 83, and about her urination. And she is suffering from incontinence. And I'm old. There's nothing for me. I don't want to try anything. I don't want to try any drug. I don't want to try any medication. She'd just written it off, that this was something that was a part of growing old, and that she didn't think anything was going to work, and she didn't want to try anything, and she just didn't want to bother. I think it's at least worth an evaluation before making that determination, because a lot of women I see have been living with incontinence for years with this thought. And in a few very basic visits, we can get their lives better, right? So I don't want you to leave this talk with that feeling. And again, they think their symptoms are due to aging. I can't tell you how many times I tell people in office, well, as you get older, and they all roll their eyes, right? But it's real. and it needs to be included on this list. All right. So the reason the type of incontinence is so relevant is because not all incontinence responds to the same treatments. The pool of treatments we have for urge incontinence is very different from the pool of treatments we have for stress incontinence. And so we may bug you to death with question, question, question. We may even do additional testing to help us figure out which is predominant for you, but it's very important in figuring out which category you fall into, because that's what drives what treatments we offer you. All right. So for urge incontinence, for that bucket, literally, we have a range of non-surgical options. A lot of them we spend, not enough time with in office discussing, honestly, but I think are really relevant, particularly for patients with mild incontinence. Modest changes in lifestyle can really, really impact your need to wear that panty liner at all, or improve your confidence when you go dancing. Um, it sounds hokey, but some basic lifestyle changes can really make a profound difference in how much incontinence you experience and how you take that weight of incontinence from your day-to-day worries. All right. So non-surgical options include pelvic floor exercise. Sounds crazy, but it works, as well as changes in diet. Most commonly for my patients with urge incontinence, caffeine is a huge trigger to incontinence episodes. And so depending on the patient, we're going to spend a lot of time about what you drink, when you drink that, can we substitute, or how can we modify your diet to cut down on the frequency of these episodes. I know that if I see a patient in office, I can hand her a list of instructions to how to do Kegel exercises, which you may or may not have heard about in the past. I do them, and I can honestly say they are exceptionally difficult to learn how to do, particularly if just from written paper. And what can be difficult about Kegel exercises is knowing when to do them, how much to do them, am I doing them correctly? We know that if I give someone Kegel instructions, only a third are going to do them properly in a way that's going to give effect. So out of this comes the school of pelvic floor physical therapy. And that's teaching patients how to do not just Kegels, but other maneuvers or exercise to try to tighten that pelvic floor and cut down on the amount of incontinence episodes that you experience. There's a huge range of types of pelvic floor therapy that's available to people. I try to refer only to pelvic floor physical therapists that I have a personal experience with and that I know are able to get really effective outcomes for patients. So we'll get to this, for everyone, it is a possible option for you. The key aspects of it are: one, time to go to the therapist, and then two, willingness to do the exercises at home alone. But for the majority of patients willing to make that investment, the rewards can be really huge. I'd say for this problem, by and large, most people say, just give me a pill. And we have a huge range of oral medications that can be effective. There's two main mechanisms of action, I guess, but the end goal is the same. These medications help relax the bladder, so as to cut down on the frequency of urination, and also to allow the bladder to relax so that you're able to hold better. And when it's time to go to the bathroom, you have time to actually get there. So those are the two goals of medication. Should a patient not be interested in these other options, or they not work, then we advance to other options. Probably the two most common minimally invasive options available that are FDA approved right now is injection of botulinum toxin, which we commonly call Botox. And that is a natural compound that relaxes muscles. And it can be used in a wide range of applications. Everyone always asks me to inject their face You don't want me doing that. I'm a below the waist kind of gal. So, but certainly the most common is the cosmetic application where we inject it into the facial muscles to help them relax and you see wrinkles less. But Botox has a lot of medical applications, and the list of them is growing. For people with chronic headaches, it can be really effective. For people with chronic muscle spasm, it can really be effective. And certainly for people who have this hyperactive, overactive bladder, a little bit of Botox can be placed directly into the bladder muscle to help it relax. And so that you can hold better and then cut down on the frequency of trips to the bathroom. And we know Botox is about 80% effective, if not more, in people where nothing else is that in the non-surgical option pile worked. So it definitely works, and it's not for cosmetics. It's definitely a therapeutic option for people. Another probably underutilized but equally effective option is something called posterior tibial nerve stimulation, which is a big word. And there are a couple different systems for these. Another term you may recognize is something called urgent PC, which is the most common. And what these involved is a really sort of very sophisticated version of acupuncture. The same nerves that go to the bladder, they also have extensions that go down the leg. And we can, with a little acupuncture needle, stimulate that nerve right behind the ankle. It is not painful. And in typically weekly treatment sessions, we're able to stimulate that nerve, and it's sort of like a bladder pacemaker. Slowly, that nerve learns to relax and calm down, and that allows the bladder to relax and calm down. And it works. The patients who I've had on this therapy, I'm amazed at the success rate they have. I think the only real barrier is it requires, at least weekly maintenance. Requires weekly maintenance for the first few months, and then once a month maintenance thereafter. So some patients do feel it's a little time involved. Some patients love it if they have the time to come for visits because it's non-medical, non-surgical. It's pretty natural, right? And again, it's something in the list of what we're able to offer you as treatment options. And then the last major treatment option for overactive bladder or urgent incontinence is something called sacral nerve stimulation. So just like the posterior nerve stimulation, it works as sort of a bladder pacemaker. We are stimulating the nerve root to the bladder to try to help it relax and function in a more normal fashion. Instead of stimulating it peripherally, as we do with the posterior tibial nerve stimulation, you actually place a little stimulator that's implanted directly at the nerve root in the back at the spinal level. So certainly it's a little bit more invasive, but in skilled hands, it is a godsend. It gets people treatment where nothing else has worked. So as you can see, there's a huge range of options, and we just really work our best to try to fit the best one for you, and then also to minimize the risk and have it work as well with your lifestyle as it can. All right, so that's urgent incontinence. All right, stress incontinence. You'll notice that this list is very different for the most part. Again, we'll start with the non-surgical options. So of these non-surgical options, these are the only treatments that show up on both lists, and that is pelvic floor exercises as well as physical therapy and biofeedback. It is wonderful. These are wonderfully effective for any type of incontinence. And in fact, I encourage women, if you're here for a kidney stone, I encourage you to do your Kegels. It can only cause goodness to your life, right? So we discussed them more in depth on the previous slide. What can also be helpful for stress incontinence is something called a vaginal pessary. They come in many different shapes and sizes. We have a specialized nurse who fits patients for pessary. Most commonly, they're used when patients have sort of almost like a hernia where they have a vaginal bulge, and for prolapse is our most common application. But for the right patient, a pessary can be very helpful for stress urinary incontinence. Um, it's great because, again, it's non-medical, non-surgical. And if we're able to find a pessary that fits and works for this indication, the maintenance isn't significant. So for the right patient, yeah, we can try it. Moving on to the minimally invasive surgical options. I have to say these are probably the two most common treatments we use for stress incontinence. And I just want to note, there is no medication FDA approved for stress incontinence in this country. So if you come to me and say, I cough, I sneeze, can I get a pill? There's nothing that's going to work for that, unfortunately. We either have the non-surgical options or some sort of procedure. Okay. And the two most common procedures we do fall in this minimally invasive surgical option category. Option one is something called injectable bulking agents. And there are several of these on the market of different compositions. No one is superior yet, although we're always looking for the best one. And what they're involved is with a special cystoscope, just through a tube, we try to numb up the urethra and we inject a medication along the urethra to help plump it up, to help give it increased tone. So in the previous side, say with the intrinsic sphincter deficiency, these types of bulking agents are critical. And in certain people, the urethra itself is just incompetent. It just does not have adequate tone. And uniquely, these agents are critical in reestablishing that tone that's necessary to keep people from leaking. Although we do also use bulking agents in patients with hypomobility as well. And then the mainstay of treatment for stress incontinence is something called a urethral sling. And what that involves is some sort of material. This is done under anesthesia, but an outpatient procedure for the most part. Some sort of material placed under the urethra to help support it and restore that pelvic floor support that has been lost through all the factors that we mentioned on the previous slide. And then the last surgical option, and I have to say, these are almost more of historic interest. We don't really do them that much anymore, but I think for thoroughness, they're included on the slide. And particularly for patients who are a little bit older, you may have had these procedures in the past. And there's a whole series of procedures that involve supporting the urethra by affixing it to the abdominal wall and through sutures that are not visible. And they fall in three different kind of categories. There's the bladder neck suspension or the Marshall-Marchetti Krantz procedure, the MMK, or Birch-Copel suspension. I think these are mentioned more of historic interest. What we have learned over time is that they fail. So say if you talk to your grandmother and she goes, I had some sort of procedure 30 years ago and it didn't work. It worked for a while and it stopped. They probably had some sort of these suspension type procedures. In rare situations, we employ them in the modern era, but like not too much. So I typically don't include that in my general discussion about treatment options. But if someone has a particular interest, we can go into those. It's more that I know about them, so I can help you best. All right. And then this beast, the mixed incontinence. And again, that's for patients who have both leakage with coughing and sneezing, stress incontinence, as well as that urgency and urge incontinence. This is the reason it is so important is that the treatments for stress and urge incontinence are different. And so therefore it's very difficult to find one single treatment that's going to really fix this problem. This is a situation where we sometimes need to do bladder testing, something called urodynamics. And this is a situation where I'm straightforward. I'll tell patients, we may need to try a couple different things, or we may need to try a combination of things to get you to a satisfactory level. But again, in most patients, we are successful. All right. So we're kind of getting to the end of our talk. I feel like I've been talking too much, and I look forward to your questions. But I think these last slides really kind of take it home. What can patients do? What can you do before coming to me to, uh, be more informed and be as best prepared as possible for our treatment options? Well, I think one of the most important things is coming to webinars like this and really being educated as to the disease process, knowing what to expect when you come see us in office. Um, all of these things really uh, uh, facilitate you getting the specialized focused care you need to get a good success. So step number one is always knowledge. Number two is talk to your physician about symptoms you're experiencing. I get a lot of patients who never tell their primary that they're having incontinence. These visits get crammed, or they just don't want, it slips your mind, or you just don't want to complicate issues. A great first stop is always your primary care physician. If you so choose, though, you can always come directly to us as specialists, and we will be more than happy to give you a thorough evaluation and talk to you about treatment options or any other testing that may be necessary. There are, as a urologist, and all my partners are these strapping, awesome, handsome men. We are all trained in the management of incontinence of both men and women. As urologists, this is, avoiding dysfunction. The act of urination is a huge part of our practice, something we take pride in managing patients appropriately. I think a lot of times a primary care physician will initially try patients on medication, and I think that's totally reasonable. But should medication not be helpful, or there be complicating factors like stroke or multiple sclerosis, in particular neurologic disorders that may complicate things, I think it's critical that a patient be evaluated by a physician who specializes in avoiding dysfunction. I'm a urologist, so I know what we do, but there also are urogynecologists who play a role in management of incontinence. But certainly as urologists, this is our bag, right? So there is a website that's on this slide called www.chooseu.com to give a list of providers that you can start with that have self-declared, we're interested in urination. And the list of providers on this site are more than willing to meet with you, review your individual situation, and try to come up with a treatment plan that'll get you where you hope to be. All right. So thank you for taking time out of this cold, horrible Tuesday night to listen to me talk a little bit about some of the principles of incontinence.
This concludes our webinar, and have a lovely evening.